Hey there, my name's Dr. Topher Fox, and today I'm going to be speaking about hyperparathyroidism, primary hyperparathyroidism and secondary hyperparathyroidism. And the hope here is that by listening to this training, when you meet me in clinic, a lot of the basics will be covered, and we'll be able to talk at a really high level about you and your specific circumstances so that you get the most out of your visit. So it's to give you the basic understanding about why we care about parathyroid glands, what they do, and why they're important. So I'm going to jump behind the slides here. And let me scoot over here just a little bit. So again, we're going to be talking about this thing called hyperparathyroidism, primary and secondary hyperparathyroidism. And what we're going to cover is a little bit about parathyroid physiology. We'll talk about the different types of hyperparathyroidism and how they're diagnosed. And then starting with primary hyperparathyroidism, we will work through causes, symptoms, and how it's treated, or maybe a better way to say it is how it's evaluated and potentially monitored. And then we will talk about secondary hyperparathyroidism as we wrap up. So let's dive in. Primary hyperparathyroidism, secondary hyperparathyroidism. So what are the parathyroid glands? In your neck, you have a thyroid gland, this butterfly-shaped gray structure on the diagram that lives here in the lower portion of your neck. And the thyroid gland makes hormones that control the metabolism. Now, it's interesting, a lot of people get thyroid and parathyroid confused, and it's understandable, they sound quite a bit similar, but the parathyroid glands, that root para, literally means next to. And so the parathyroid glands, there are usually 4 of these that live next to the thyroid gland. They're a completely different system. They do a totally different function than the thyroid gland, but they share the same neighborhood. And so they share a portion of the name. So parathyroid glands, there typically are 4 of them. Interestingly, there can be fewer, there can be more, depending on how you developed as an embryo. And the parathyroid glands make this hormone, PTH, parathyroid hormone, which is designed to help protect your body against low calcium. So parathyroid hormone induces some changes in your body that will help to raise the blood calcium level. Now, when we talk about primary hyperparathyroidism, that term hyperparathyroidism means high parathyroid hormone or high PTH. And we see that in primary hyperparathyroidism, 1 or more of these glands is no longer functioning correctly, no longer sensing the blood calcium level correctly. And so we will typically see a high PTH and a high calcium level. Now, interestingly, 1 or the other of those could just be at the upper end of normal. So an upper normal calcium with a high PTH or an upper end of normal PTH with a high calcium would still be indicative of primary hyperparathyroidism. And primary hyperparathyroidism, if it needs treatment, is generally treated surgically. We'll talk about that more in a minute. There is another flavor of hyperparathyroidism called secondary hyperparathyroidism. And this is seen when the PTH level is high, but the calcium typically low or at the low end of normal. And in this case, the parathyroid glands are simply responding to a signal. And our job is not to think about surgery, but rather to identify what's causing those parathyroid glands to be overactive and to try to fix that cause. So it's generally a medical treatment rather than a surgical treatment. Now, before I leave here, I should mention that there is a molecule, a substance, a vitamin actually, called biotin. And biotin is known to interfere with a number of hormone test processes, hormone test results, including PTH. And so when we find that PTH is elevated, we want to make sure that it's not because you've been taking high doses of biotin for your hair or for your nails. And so generally, if that's been the case, you've been on those things, it's worthwhile to repeat calcium and PTH measurements after you have stopped the biotin for at least 72 hours, 3 days. Okay, why would primary hyperparathyroidism occur? Why would those glands malfunction and cause the PTH level to be high? Generally, probably 80 to 85% of the time, it's because of this thing called a parathyroid adenoma. One parathyroid gland essentially has a growth, a benign tumor, not a cancerous tumor, a benign tumor that has caused it to stop sensing calcium normally and to overproduce PTH. And so PTH levels will go up and eventually calcium levels will rise. Now, maybe another 5 to 10% of the time, we have what's called a double adenoma. So there are actually two of the parathyroid glands that have that growth. And then the remaining percentage of the time, probably another 5 to 10% of the time, all four glands are a little bit overactive in something that's called parathyroid hyperplasia. And as surgery is performed, if needed for this condition, the surgeon will typically try to distinguish between these. And they actually do a wonderful job at being able to distinguish between these things. So what happens when people have hyperparathyroidism, particularly primary hyperparathyroidism? What we see is these symptoms probably are driven mostly by the calcium level going up rather than the PTH level, but they can include things like fatigue, weakness, abdominal pain. A lot of folks will have nausea and constipation. Sometimes muscle or bone pain, muscle weakness, increased urination, depressed mood, brain fog, poor concentration. All of these things have been associated with hyperparathyroidism. Acid reflux, high blood pressure also have been associated with hyperparathyroidism. And the tough thing about these symptoms is they're what we call nonspecific, meaning these symptoms can come from that high PTH, high calcium situation, but they can also occur for lots and lots of other reasons. So there's a lot of overlap there. So we're always trying to look at symptoms plus the results of blood testing to make that diagnosis. Now, hyperparathyroidism has two real complications, two downstream results that are really the most problematic, and these are bone loss or osteoporosis and kidney stones. And we'll talk about those in a second, but those are things ideally that we would like to prevent by treating this condition when it is identified. And this isn't really common, but occasionally we'll see folks present with a very high calcium level. And so usually we start to get more concerned when the calcium is a full point above the upper end of normal. So if calcium normal goes to 10.4, we get more concerned when it gets to 11.4 or above. And severe hypercalcemia is where the calcium is generally in the 12s or higher. And it can be associated with really rather severe symptoms. People being extremely lethargic and weak, lots of nausea and vomiting, and can progress to a comatose state. And this is actually a medical emergency. So when this occurs, and most commonly it occurs in people who have hyperparathyroidism and then get dehydrated, it's very important, obviously, if somebody is comatose to get medical evaluation straight away. So what is the treatment of hyperparathyroidism, primary hyperparathyroidism? Really, the first job is to decide, is treatment needed? Because we measure calcium routinely, and we know that this condition, primary hyperparathyroidism, occurs more frequently as we get older, a little bit more in women than men. Because it occurs relatively frequently, sometimes it's identified and it's not causing any problems. And in that situation, we may be able to go with treatment number one on this page here, just the simple monitoring. The main treatment, if treatment is needed, is a surgical treatment. There is something called minimally invasive surgery, which is the most common approach these days, which is where we do tests before surgery. These include ultrasound, CT scan, a nuclear scan called the sestamibi scan, or sometimes even MRI. We do imaging to try to give the surgeon a roadmap to say, hey, which of those four glands is the culprit? And when the surgeon does surgery, they will try to go straight for that culprit gland. They will typically do some testing in the operating room as they remove that gland to confirm that it looks like that has treated the situation. There is standard surgery, which is simply for people that we don't have a good roadmap. The surgeon will go look and identify all four glands and simply remove those that look abnormal. And before about 2000, this was really the year 2000, this was really the standard treatment. And it works great. It cures the condition in over 95% of cases. that minimally invasive approach has allowed surgeons to do a little bit less involved of an operation, and it's allowed people to often go home the same day as their surgery. So it has some advantages, but it's not needed if, for some reason in your case, it can't be done. Now, for people who have this condition that needs treatment, but can't be treated surgically for whatever reason, either because of other medical conditions or because of preference, then we know that in particular when bone health is the concern, that osteoporosis medications may have a role. If kidney stones are the main concern, there may be ways to manipulate the kidney stone risk, for example, just staying hydrated. So there are potentially medical options that could be done to treat those complications. Now, in general, surgery is recommended by experts who discuss primary hyperparathyroidism. Surgery is recommended for people who have kidney stones, either symptomatic kidney stones in the past or kidney stones on imaging, because when people have curative treatment, they will stop forming new kidney stones. Now, importantly, if kidney stones are still in the body, those still may need to be passed at some point and still can cause symptoms, but typically new stones stop forming. And osteoporosis, we know that when this is treated, bone density tends to actually go up a fair amount. So surgery is generally recommended for those who have osteoporosis, those who have a particularly high calcium, a full point or above that upper end of normal. Very high urinary calcium, often 400 milligrams per day or above normal. It's usually going to be less than 300. Very high urine calcium or high kidney stone risk. If there is decreased kidney function or age younger than 50, these would all be people for whom we routinely recommend surgery. Now, there are some people with this condition who don't have any of those criteria, but just feel lousy. Lots of fatigue or brain fog or depressed mood. And what we know is that probably for about 80% of people, when they go through surgery, quality of life goes up, symptoms go down. But we just have to be cautious if that is the main indication for surgery. If we're doing surgery for fatigue, we have to realize that there is a chance that surgery might not improve the energy level. We can talk more about that at your visit if that applies to you in your particular circumstance. Now, after successful surgery, typically there's lifelong monitoring to check a calcium level each year, to measure the vitamin D level periodically, and to monitor the bone density, particularly if it was low to start with. Okay, so that is a big mouthful about primary hyperparathyroidism. Let me just conclude with a few words about secondary hyperparathyroidism. So again, in secondary, as opposed to primary, so primary, the glands are malfunctioning and we need to look for the abnormal one to remove it if we're going to treat this surgically. In secondary, the parathyroid glands are responding appropriately to some signal that is causing the blood calcium level to decrease. Now, it may not be frankly low, but typically it's dropped some in the body if we had before and after measurements. And so our job is to try to identify that signal. Typical signals are going to be a low vitamin D level, abnormal kidney function, poor calcium absorption, or a low calcium diet is what that's supposed to say behind there, a low calcium diet. Or there is a condition called idiopathic hypercalciuria, big mouthful, sounds like doctor terms, but it's a condition where the kidneys essentially are leaking calcium and the calcium level in the urine is elevated. So we see calcium is always leaking out into the urine, and the body to protect that situation, keep the calcium from dropping low, will raise the PTH to take calcium out of the bones to put it in the blood. So it's going from bones to blood to urine. And we do care about both primary and secondary hyperparathyroidism, primarily because of that bone health, or often because of that bone health. We know that the elevated PTH can affect the strength and integrity of the bones over time. So again, primary hyperparathyroidism, typically a surgical treatment or trying to decide if surgical treatment is needed. Secondary hyperparathyroidism, looking for that cause, trying to correct it. So again, today we've covered parathyroid physiology, the different types of hyperparathyroidism, how they're diagnosed, and then for primary hyperparathyroidism, the causes, symptoms, and treatment, and a little bit about the treatment of secondary hyperparathyroidism. So I hope that whirlwind tour of the parathyroid world is useful for you. My hope is that when you come and we chat in clinic, that this will make our discussion occur at a really high level, that a lot of your basic questions will already be answered, and we can really dive into what's most important for you. And so your homework, if you haven't done it already, is before your first visit with me, make sure to get those 2 forms done, your 2 new client forms, the registration form and the medical history form. And I look forward to meeting you in clinic or on telemedicine. And until that time, I wish you peace. Take care.